I would like to just give a couple of items as far as background and setting the stage before we transition over to our presenters again. Oh, thanks, Stephanie. I see you don't see the link in the chat. Let me throw that in there again. Okay, so the Padlet link you'll see there, and that'll pull up the website. Thanks. So this is the first of our TA series kind of across the sequential intercept model, and we're using that to kind of set a framework for the topics that we are covering in these several months leading up to the hopefully in-person network meeting in Atlanta in September. And these topics are all drawn from the 11 Impact Network sites. There was a poll that we had at our last meeting to kind of rank folks' interest as far as the different topics. And so we've taken those and again, organized them across the SIM model. So you can see that we're using this as kind of a structure. We're starting first with intercept 0 and 1 for both today's call and the next call, which we'll announce at the end of today. And then as the intercepts follow, you'll see we'll cover kind of some different topics, again, based on folks' interests. So looking at 0 and 1 today, and specifically this population specific approach to knowing and sorting your population in order to serve your population. And today we'll be covering in particular the group known as familiar faces, most visible persons, sometimes high utilizers, depending on where you are. But Reggie and Katya Sharp will talk about some work that they've done both in Denver, both of them actually coincidentally in Denver, and then also with Middlesex County. And I think provides some really rich foundation to this area of population-specific approaches and how they've used it kind of in different ways in both Denver, again, and Middlesex. So I will hand it over to Reggie, first of all, to give some foundation and then talk about Denver. Thanks, Reggie.
Thanks, Ashley. Good morning, everybody. So when we think about creating system change, there's a lot of different things that go into that. And as Ashley's saying, we're here really focusing on different ways to think about and look at your data. And so on this particular slide, and you again will have access to the slide decks, these are just some of the thoughts when you're thinking about creating change to kind of put foremost in your mind. And part of that is, what are you trying to solve? So what is the issue? What's the pain point that you're trying to address here? And why are you trying to solve this particular issue? So part of that is who and what are the impacts of the current issue that's taking place, and what's the data that supports that. And you're going to see in this presentation and also in Katya's, we're really trying to help queue up looking at this through a data lens. And then what is the current state, what's the desired state, and who's going to win and lose in those different areas. So I often use terminology of pain points. You also hear me use sometimes terminology around what's called lean, which is a way of thinking about how do you eliminate waste versus huge kind of systemic change. The other things that you're going to hear me talk about are issues around cost. So what is the current cost? Are you looking for a cost shift, which actually is often part of the work from a criminal justice behavioral health lens, or is it a cost avoidance, cost neutral, cost increase? And then what needs to be leveraged and what needs to be influenced. So when we think about our folks with most visible persons, as I will refer to them largely, those are folks that are often seen in the public eye. And there's a lot of part of the issue, part of the reason that they're visible is because there's a lot of public outcry about those particular conditions. So oftentimes your business community in your kind of central business area is going to be hardest hit, and other kinds of public places like libraries and those kinds of areas are going to be often hit with this particular population. And what can be influenced? So sometimes what you want to think about is how do you educate then the public to understand what's actually taking place with a particular population? So you want to look at your laws, your policies, and your practices, and you want to look at those through a lens of what's helpful, what's challenging, and what's needed. And then looking again at your existing resources, how those resources are currently being utilized, who your partners are, and what partners are needed to be able to help you. And we'll talk about those particular issues a little bit later on. And then I always think about this work from 4 different strategy levels, from a system, policy, and process level. So that's when when we're really thinking about, well, this has an impact on the system. And you can think about that from a criminal justice system, from a medical health system, from a behavioral health treatment system, from community kind of government, the flow of your city. There's a lot of different areas to think about, but also really want to queue up thinking about this from an individual and then a population side. So that individual level, but also kind of when you start aggregating individuals are similarly presenting themselves, you start getting at a population health type of view. And then really looking at the geographic and location level. So not just thinking about how do you change systems, but what areas, whether that's a building or it's a park, or it's a certain kinds of area. And I'll show you some examples of that later on. So some of the big keys on this is looking at matching up data, looking again at who needs to be engaged, and really looking at if you're trying to create system change, what's available to you? Again, that leverage and influence, what's available to you? How do you access different kinds of services? And what's the capacity? What we see all too often is that, yes, there are services, but they have limited hours of operation, or they are not accessible. It would be an hour, 2 hour in a larger city bus ride to get across town to be able to get that particular service. And you're likely not going to have people that are going to actually engage. Actually, if you go to the next slide, please. So just a couple other things around data and really thinking about population. Part of it is, where does the data exist? So I used to be the criminal justice coordinator and ran the Office of Behavioral Health Strategies for the city and county of Denver. And in the justice system alone, between the juvenile adult system and between the criminal justice and civil system, which would be our and I can't think of not our probation, but our, it'll come back to me. Anyway, our other court system, or probate court, there it is. We had 9 different systems that we were trying to coordinate across. And not everybody used the same kinds of data. So we had to do a lot of matching with our data to make sure that when we were talking about Reggie, it was the same Reggie across all of our different systems. So looking at, where did your data originate? Are you getting it in an open kind of flat file? Are you getting it on an individual basis? Is it protected data? So all those things are important to take into consideration, but also understanding in its particular, and how it's being used. Is it used right now for transactions? So jail data is often transactional data. So sometimes it's hard to pull trending information out of jail data, because a lot of times it's about they move from this point to this point. And so if the data system is not set up to be able to trend it, it can be very hard to really do some evaluation about what this particular person needs, unless you're doing it by an individual basis. And then also looking at terms and definitions. I always encourage locations to create a data dictionary. For example, when I was doing work in Denver, we had, I think it was 5 different definitions of recidivism, depending on if you were talking from a court level or from the jail, or if you're talking through district attorneys. They all had their own definition of what they called recidivism. So what we just simply did is said, everybody can keep their own definition, but for the use of our data, when we're putting data reports out, this is how we're going to define recidivism. And my very, very large committee all agreed to that. And then, how is information shared? Is it through a memorandum of agreement or understanding? Do you have to have an IRB? Are you making sure that you have client consent and release, especially for studies? Are you looking at it from aggregated? Are you using proxy data? And then, how is it being tracked and analyzed? So there's a lot of different things that come into this. Part of it is always thinking about, what are you going to end up reporting? And what are those kind of key performance indicators you want to make sure that everybody's agreeing on, and that they're really going to tell the story about what your issue is and what your desired state it looks like. And then always looking at costs and returns. I think looking at costs is probably one of the areas that I see systems struggle with the most, because they forget about it. So it's not just enough to look at the data, but really tying its cost to that particular data. And I'll show you some examples of that. So this MVP, as I have it shown here, is those most visible persons. That's a term that came out to me from working in Kansas. Actually, a group there was using that, and I like that a lot. But for that particular work, really looking at, again, what's the specific data sources? Who's the target population? So you start really getting, when you're doing most visible person work, you're really looking at a population health, and you're going to have to create some cutoff points. For a lot of players, it's going to be 3 or more contacts in a year, maybe for jail, or in a month, if you're looking at healthcare type of data. And you're going to start seeing kinds of subpopulations come out of that, especially when you dive into race, ethnicity, gender, and age type of populations. You want to pay attention to who's being served and who's not being served, and why they're not being served. For example, when I was doing this work, and some data I'll show you examples of, we were working with a population that was in the downtown corridor, and our mental health police officers who were specifically on a mental health team did not know this population, but who did know this population was our homeless outreach officers. However, the folks who were working from the shelters in the city and county of Denver who did homeless outreach, so civilians, didn't know this population. And that was because this population had a very high substance use needs, and they were basically, if outreach people were coming up to them, they were like, I don't want to go to a shelter, because the shelters were dry shelters. They didn't allow for anybody to be under the influence to come in at that time. And so it was the law enforcement officers on homeless outreach that knew the population, even though this was a population that was both homeless and also had serious mental illness and co-occurring substance use. Also looking at how they're served, what's the impact of those services? Who's paying for those services? Sometimes what we found is that the jail really knew this population well, and the ER system knew this population, and detox knew this population, but there was not the right kinds of services and the right kinds of depth, so the frequency and duration of services that were needed to really be able to manage this particular population and to stabilize them. So sometimes we wait for people to fail. That's a big issue around insurance, where you have to have the lowest level of care, but sometimes the people who are coming to us really need a higher level of care. And so it's looking at it from all those different kinds of lenses, and then where the services provided. To go to the next slide. So again, a little bit more in depth and looking and trying to give a face to those most visible persons. I want you to think about that. Most visible persons, again, are those folks that those phone calls are coming in consistently because they're perceived as being blocking an entranceway to the business community, or they're acting in a way that other people might find disturbing because of either substance use or untreated mental illness. But we often then just kind of, we treat them as if they're invisible, except for when we're trying to address whatever this particular cue is that they're giving to us. So who are they visible to? Police, jail, local emergency rooms, detox, the general public? How are they visible again? And to whom are they visible? All these different areas. Why are they particularly visible? What we found again in this particular population is that this was a population that was unhoused, serious mental illness, serious substance use disorders, and we had barriers throughout the system for them to be able to get the level of services that they needed. And then what are those particular impacts that are taking place? If you go to the next slide, please. So part of our work then was to start looking at individual population data. So I'm really going to stress that it wasn't until we started to look at the individuals. We pulled data based on court data. I'll get into that a little bit more. We looked at court data and just did an analysis of not what charges, but who was coming in most often to the court. And this particular data set that we started with was at the municipal and misdemeanor level. And so then we started to, and that was a criminal justice level, so we could actually share that data list. Still in Denver, they call it Reggie's List. But then we started to shop that particular list because we found this interesting pattern. And we started looking at who else knew this particular, or who else would have a pain point around this particular group. And so what we looked at was then from the population, what was the most prevalent charge? Not the most serious charges for them, but what were the most prevalent charges that were taking place, and the nature of nature and number of those incidents. And then we did the same thing around ER and homeless related data. We also then looked at jail particular data and the number of bookings per individual, and on that also the most prevalent charge. Again, I always want to queue up looking at age and gender along with race and ethnicity, because that starts getting you into your population health. You'll see that that younger transition age population is very, very different than the population that we saw in this particular group. We also looked at things like we could trend out looking at their criminal history and their treatment history or the lack thereof. We could actually see where we had high levels of drug use when they were transition age youth. And then after about the age of about 35, 40, we started seeing more and more alcohol incidents, and that became the most prevalent issues for this particular population was alcohol instead of drugs as their population aged. Also wanting to always look at that public health data and looking at the number of ER visits, detox visits, but understanding that when a person goes to the ER, what's usually served is only that presenting issue, but not looking at the complex needs of this particular person. So oftentimes they're getting triage for a particular issue, but they're not getting the full services that they need, or even the identification that they need of all the different services that are going to help them become more stable. Again, looking at homeless related issues, housing related issues, and then also benefits, including do they have benefits such as SSI, SSDI. Would also always encourage you to look up your SOAR provider within your local area. So if you go down, Ashley, want to give you how we looked at this data from our Denver lens. So here, this is back in 2012 when we first did this work. So at that point, we were not using the term most visible persons, but we were calling this particular population front-end users. And so again, we pulled data. We had just a data set that was for the last 5 years. We went back to 2012. I think I said we did this work in 2012. We were doing this work actually in 2017. We went back to 2012 to pull the data. And as we started looking at it, we started seeing this population, especially in the top 500 persons, that was very, very interesting. And so we looked at their utilization pattern. We looked at the appropriate kinds of interventions that this particular population would need as we learned more and more about them. And we put cost analysis to what they currently were receiving, and also were able to determine what the cost would be to do services differently to increase stabilization. And then we had to work with all the different moving parts from all these different systems to actually create change. Ultimately, in this particular work, one of the biggest outcomes was to queue up a social impact bond, which is a housing kind of pay for success type of model. But I will show you the outcomes with a whole lot of other data also. Actually, if you go to the next slide. So our target population became, again, this high utilizer, this front end person. And what we found is that there was this kind of chronic homeless population, but our high utilizers were very, very specific. And that's that our high utilizers, the average age was 50. And the normal age of our general criminal justice involved population actually was 36. So quite a few years older. 95% of the population was reporting being homeless. And actually of that particular group, only about 25 out of the 500 were known to the homeless services at this particular time, even though all of them were chronically homeless. So again, it was a population that was not being served by homeless outreach. And 88% of them were male. We also saw real disparity, about 11% compared to 1% of African-American of American Indian in our population, and 32% versus 10% of our general population in the city and county of Denver. And only 18% of this population had benefits. Again, this is a chronically homeless population that was coming through the system on a regular basis, and yet only 18% of them had Medicaid benefits. Part of that was because during this time frame, this is prior to 2014, which In 2014 was the expansion of Medicaid with the Affordable Care Act. And so this population was just zipping through the system so quickly, they would burn out, especially in like detox, they would burn out all those services. And so they weren't even tracking or reporting this population any longer to Medicaid. And one of the good things we found is only about 1% of this population was a registered sex offender. Whew, right? Because we knew then we wouldn't face some of the challenges around housing. I mentioned before looking at kind of your location issues. So we actually looked at and geocoded. All of our work also looked at geocoding, where resources were, where populations were, that kinds of stuff. And so this is how the geocoding looked for this particular population. And this was important to us because we could look at race and ethnicity through this. We also were able to look at age through this, but we could see the specific corridors. And in this particular case, it's the Broadway corridor and the downtown business corridor. And so we knew where we could, and the rest of it followed the river. So we knew where we needed to really concentrate our resources and our outreach. If you go to the next slide, please. We also then looked at those top charges, again, the most prevalent charges, not the most serious, the most prevalent charges. And what you see here are those quality of life type of charges. Trespass is often going to be one of the general ones that's going to show up for your systems with most visible persons. But this was our most prevalent charges. So public nuisance, trespass, and alcohol related charges were appearing. And that was, if you go to the next slide. So then we took that list of 300. Remember, we've been shopping this list around, and we could do that because it came from a criminal justice, not a protected health list. So we weren't sending it out. We weren't identifying anyone's protected issues. We were simply saying this are people came through the court system in this period of time. So we were able to start to drill down on is we then narrowed it down to the top 300 people. We were able to discover that 300 people were costing us an average of $11 million per year in the current as-is state. They had the same kind of patterns of utilization over 4 years that we were able to look at them. That becomes important. So they had 14,000 days in jail, an average of 57 days per person per year, over 2,400 visits to detox, and the majority there were being released without any kinds of services post-detox, so without an active discharge plan. They had 1,000 arrests and 600 emergency visits, room visits. If you go to the next slide, please, Ashley. So when I said we looked at their pattern, we wanted to see, does the group look the same, right? Are we looking at a very homogeneous group as far as how they're going through the system and utilizing just criminal justice resources, homeless, non-homeless, detox, emergency rooms, all of those resources? We found is no, they're not. And so we started looking, we found that there was an average of total bookings of 8 and year, total average of 8. But the 2.7 was the average of just the bookings on a year. Sorry, that's confusing. I apologize for that. They had a total of 170 days, and this is over 5 years of data. And the average stay, again, was 57 days. So you see, though, these different, when you think about, these are just 3 of the different folks, we could see that some had peaks and valleys over time. Some looked very different than that. Some seemed to have been pretty stable for a while and went up. And so then we're also able to track them with human services and other kinds of resources. Go to the next slide. Cost measures, again, were really key for what we were working on. And so we looked at jail cost, arrest cost, court cost, and medical expenses. In our jail cost, I always invite you to look at it from both the lens of marginal and variable cost, and we did that. We looked at custodial and cite and release data. So this particular population, and what became clear on this is that by looking at it from a court lens, we were able to pick up a broader group to look at how many times police were actually contacting this particular population, doing a cite and release, also being able to contact this population, and often didn't do anything because they knew if they ran their name, they would have a warrant. Because at that point, we had this evolving system where police officers would contact somebody. If they had a warrant, it was a mandatory arrest. And then the person would go to jail. they would deal with that particular warrant. They would have a ticket for two weeks down the road. They wouldn't show up for that particular hearing. Another warrant would be issued. So it had this leapfrog effect. So that was one of the outcomes of this that we tried to resolve. We looked at court cost and the arrest around that, and then medical expenses. We looked at emergency rooms, Denver Cares in general, which is the community health provider, and other medical services. If you go, and that was an average of $37,846 per person per year. If you go to the next one. So we had a lot of different collaborative partners. I'm going to skip that one. If you go to the next one. And what we came up with was we needed to stabilize this population because of the service delivery, that they were never getting enough services to really the frequency, intensity, and duration that they needed to really stabilize them. And a lot of that was because of their housing status. And so we created a social impact bond process. If you go to the next slide, what we did with that is we looked at different kinds of models, housing first, and looked at ACT models. And we looked at what we knew we could quantify the data on that to say, this is what it's actually usually costing to do those data. So we knew that if the average cost of almost $38,000 per person, we could house and provide supportive housing, so treatment services for this particular population. I invite you to look up an Urban Institute has done a full assessment on this particular work and evaluation. We now have in Denver over 375 housing units specifically for this particular population. And I think it's around 84% success of them staying housed and stable in the housing units. If you go to my last slide. So yeah, I kind of mentioned and alluded that this was kind of a kickoff. So again, we looked at this through a population lens. So looking at not the system lens of who's impacting the system, of what's impacting the system, but who is impacting the system and what's taking place. So what you see on here is that this one little study just drove us to all kinds of other work. So in the middle here, you have this court analysis, that was that major work. And so in Intercept 0 and 1, that led us to doing the social impact bond and building that permanent supportive housing. There was all kinds of great treatment issues that came out of that, because we had the Mental Health Coalition, Mental Health Center of Denver, and the Homeless Coalition came together to provide services to this population. And even though they both were really experts in providing really important services, this population they really hadn't ever served before. Or if they had, this was the population where cases were often closed because the population wasn't showing up to services. And so now through this particular work and through a social impact bond, they couldn't close that case. And so they really learned how to be proficient at providing services to an incredibly complex need population. It also queued up our needs for the co-responder model, in which Denver now there's over 24 co-responders, and so they're working 24 hours a day, 7 days a week. That eventually led to us creating something we call substance use navigators, which are similar to co-responders, but specific folks around substance use, peers in there. It queued up our lead law enforcement and assisted diversion program. Eventually all that data queued up something that's called STAR, which is really a cahoots model. It also, all this data started queuing up our need for a solution center, which has now opened in the city and county of Denver. And on the third floor of that solution center, there is a 30-bed facility for persons who are experiencing homelessness to stabilize them. So past the immediate needs of the mental health crisis, we actually are stabilizing them there for 30 days. It also queued up some direct work with our American Indian service providers in the area, because again, of that 11%, that overrepresentation of that particular population. It also helped us understand that we needed to look at 911 data, so that nature code data, and really analyze that about who was going out to provide these services. And it wasn't just police, but it was also fire services. And so from that particular work, we created an in-reach with at the shelters through the FQHC that was being operated by the Homeless by the Colorado Coalition for the Homeless to start anticipating people's medical needs instead of them calling for emergency services. We also started doing a deep dive with detox and looking at their most visible persons. We worked to combine cases and charges so that we no longer had that leapfrog effect. And Intercept 2 and 3, it was able to queue up warrant and FTA particular data. We created court reminders from that. We also then created an entire court just to serve this particular population, those that we didn't deflect. So we created a recovery court. We also created a homeless outreach court that's actually operating in homeless shelters, as well as actually working with encampment-based folks. And it really queued up our information and knowledge around the IDD and the acquired brain injury population, since this population had such complex needs that was co-occurring with substance use and mental health. And then it also queued up in Intercept 4 and 5, a whole different level of jail reentry, jail services and reentry services for those folks who did go to jail. And then also queued up at the state level, county and state probation level, really, and prison, looking at complex needs. And we created something called a phase day reporting that was run out of a sober gym, where this particular population, again, high homeless population, they had all kinds of technical violations and revocations, and that we were able to cut that down because we created a whole strategy of this particular population being served in a sober gym where we had treatment services, and the probation and parole officers reported to that sober gym with this population. Peer services were there, and we were able to do yoga and boxing with them. And it's been unbelievable, that partnership. So that particular population was now being served in a different location. They no longer had FTAs and revocations because probation and parole were able to go to them and be able to address their needs. And then we had treatment services. So that's just an example of how we use data. Let me turn this over to Katya to talk about her work in Middlesex. It was really my pleasure to meet Katya long before actually she went to Middlesex, when she was part of the Harvard government policy lab. And so performance lab. And so I met her there when she was actually working in New Mexico. But Katya has found her way to Massachusetts, and let me have you talk about what you've been doing in Middlesex.
Thanks, Reggie. Yeah, so we'll give you some more information about that resource, the Harvard Government Performance Lab, at the end. But yeah, as Reggie mentioned, I was doing a lot of this similar data work out in New Mexico, and now I want to talk a little bit about what we're doing in Middlesex County, Massachusetts. We're one of the impact sites. So if you want to dive into the first slide, there we go. So in Middlesex County, Massachusetts, we were seeing really high and increasing rates of behavioral health conditions among the individuals booked into the Middlesex County jail and prison. And so confusion here really kind of raised that as an issue with the state legislature. And also at the same time, the state was really seeing high and increasing rates of emergency department boarding, and specifically seeing that a lot of that boarding was due to behavioral health crises. So that boarding is referring here to people who spend many hours, more than 6 hours, in an emergency department awaiting placement in an acute crisis bed for behavioral health. So those two things were happening simultaneously, and lucky for us, folks who were elected and who held some ability to pass statutes in the legislature kind of raised this as an issue. And so as part of our criminal justice reform bill in 2018 here, the state dedicated funding to create a commission to look into creating a restoration center based on the San Antonio model that could address this kind of dual need of individuals with whose behavioral health crises are driving high rates of both incarceration and high rates of hospitalization. So if you move to the next slide, in order to really dive in, once we were tasked with this problem, we really needed to better understand who is it that we're trying to serve, what is currently happening to them, why is it happening to them, and will our proposed solution kind of resolve those issues. So we really set out over the course of the last 3 years to define that problem much more specifically, really dig into the data on who is our target population for this restoration center, what is that target population currently experiencing, and how can we reverse those cycles? So we really set out to say, who are these individuals familiar to? What parts of the system are they touching? How are they familiar to these parts of the system? Why are they interacting with these parts of the system? And what's kind of the underlying need that is driving all of that interaction? So if you go to the next slide. So the first question we set out to answer was, who are these folks familiar to? So we knew that they were familiar to the sheriff. So, among the individuals in the jail and prison at Middlesex County, about 50% at the time had a mental health condition, 75% of those individuals had a co-occurring substance use condition, and 80% of the folks held at the jail and prison overall had a substance use condition. Those numbers are probably going up since we did this initial data look. Especially as with COVID, rates of incarceration and detention are really declining. And we also found that detoxification procedures in Middlesex were really high and really seeing a lot of opioid and alcohol withdrawal as people entered. On the other side of this was we were seeing reports coming out of the Massachusetts Health Policy Commission, which is a kind of research group around healthcare in Massachusetts, really kind of putting numbers to this problem of emergency department utilization and boarding among people with behavioral health conditions. So, the HPC put out a report that showed that, even though behavioral health emergencies were only accounting for 14% of ED visits in 2015, they actually accounted for 71% of all of the ED visits that quote unquote boarded or spent longer than 6 hours waiting for actual treatment in that emergency department. And 63% of those visits were by Medicaid members. So we felt like these populations were very similar in terms of the outcomes that we were seeing. And we wanted to dig more into exactly what were the pathways that these folks were traveling to get there. So if you move to the next slide. Our next question was, why are these folks familiar to these two systems in particular? And so we tried to go a little bit farther upstream next in our data looks. So, we know that people who end up in the jail and prison and people who end up in the hospital probably went through some kind of law enforcement contact or the 911 system. So what we ended up doing was surveying the police departments in Middlesex County, of which there are 54, to ask, how are these people interacting with you? What are you seeing on the ground? And most of those police departments run 911 systems. So we were getting a little bit of a clearer picture in terms of how people were passing through 911 and ending up interacting with police. So 75% of officer time may be spent on behavioral health calls, according to the police chiefs that we surveyed. We also looked at some actual data in two departments. As many of you are probably aware, police data can be challenging to use in this manner because, at least in Massachusetts, incident reports, which collect the information that we wanted about what was actually happening on the ground in the police interaction and what was the disposition of that interaction, that information is kept on paper. It's not kept in kind of a database where you can look at thousands of records at once and kind of collate them and analyze them. So what we had to do was work with several people to look by hand at police reports over the course of 2 weeks in a couple of departments and by hand identify which ones were related to behavioral health incidents. So in Arlington, Massachusetts, we found that of all of the police interactions, which were about 429, we were finding about 6% of those were with individuals who had a mental health or substance use condition. And that was at the same time that we were hearing from police chiefs anecdotally again that they thought 75% of officer time was spent on calls interacting with those same individuals. So small number of individuals spending a lot of time and resources for the police. And then on the right here, what you can see is we worked with another police department in our jurisdiction, which actually started putting together some vignettes of individuals that they were seeing. So this vignette that you can see is one individual and the number of interactions that they had with first responders in the city during the course of 2 months. And so you can see, there were at least 5 different times where this individual was civilly committed to a hospital for a behavioral health condition. That's in the green. The yellow is the number of EMS transports to a hospital per day. And the orange and red are the number of times the individual was arrested. So as you can see, this is again adding to our information that we have about how people are interacting with law enforcement and ending up in those two kind of outcomes that we were most interested in. So if you can advance to the next slide. We also, in addition to knowing that folks are going through law enforcement and the 911 system to end up in the jail or prison setting or in the emergency department setting, we also in Massachusetts are lucky that we have mobile crisis teams that are covered by the Medicaid system here. And those mobile crisis teams have existed for a while now. And so we were able to actually get access to data about, de-identified data about how people were accessing that type of system. And you can see the outcome of some of that data analysis here. So on the left-hand side, you're seeing the location of the person calling, seeking to access a crisis assessment, which is a determination as to whether an individual requires a hospital level of care or not. And you can see that the location of the crisis caller was either in the ED, so they either went to the ED and sought a crisis assessment. The police may have interacted with someone through the 911 system and asked for a crisis assessment, or the most common way, 75% of individuals themselves are calling for a crisis assessment. They're calling this provider entity to come out to their house or to wherever they are and do that crisis assessment. In the middle, you're seeing the location of the assessment itself. So after, 75% of these callers are calling from their home or from some community-based location, seeking this crisis assessment. The provider is then doing 89% of its assessments in an emergency department setting. So what that tells us is all of these people are seeking crisis levels of care from their home or from some community-based location, but they're still ending up in the ED for some reason. And then as you can see on the right-hand side, the disposition of the crisis episode, most people, and these are the categories circled in red here, most people are not ending up in an acute hospital setting. So most people are seeking crisis assessments, ending up in an ED for that assessment, but then not ending up in a hospital at the end of the day. So why do they need to go to the ED for the assessment was kind of our question. And so I think this really kind of clarified for us that parts of the system that are intended to be diversionary are in fact not being diversionary, and to try to kind of get to the bottom of why that's happening and how this restoration center can flip that model. And you can advance to the next slide. And so another part of what we were looking at was how to use the data that is available in police departments and in the 911 system itself to really, again, direct people towards the restoration center and diversionary levels of care and away from these two outcomes that we weren't interested in. So the second type of data that we were able to ask about with police departments was in the 911, what they call CAD system, the computer-aided dispatch systems of our police department partners. We asked about whether they track behavioral health calls. And what we found was that most of the police departments that we surveyed are including a mental health flag of some kind in their CAD system. So they're tracking to some extent the mental health calls that they receive. However, we also know that that's a kind of a new trend that's beginning, and we also know that the mental health flags that they're tracking are kind of ruling out all other codes for calls and ending up with a mental health call. So the mental health call code here is probably not it's catching people who are not otherwise falling into an existing code category, like violent incident or EMS need or something to that effect. So we definitely think that there's more work to be done to increase the number of call codes that relate to behavioral health to better track who is using the 911 system and how police are responding to those systems. And so what we think that this is kind of why we're seeing that discrepancy in the low number of the low call volume that police are tracking in terms of behavioral health, but then anecdotally saying that there are really high numbers of officer time being spent dealing with people with in behavioral health crisis. So you can move to the next slide. And so we took all of these disparate sources of information and we tried to weave them together into a picture of who is our target population here for the Restoration Center, what is currently happening to them, how are they traveling through this system and ending up in these two outcomes that we're looking to divert them from, and how can we really change the way that their pathways are looking now by creating a Restoration Center. And so we basically put together this view of how many people we might serve on a monthly basis on a daily basis in a Restoration Center in different parts of the county, based on how many people we think might be a police referral, how many people might be diverted from an ED setting, how many people might be re-entering even from a jail or prison, how many might walk in on their own, and then how many people might be coming from surrounding areas. And so these are different parts of the county that we're showing here, but really we're showing 8 to 18 daily intakes for a Restoration Center in any given part of the county. So you can advance. And so based on all of that information, we got a better picture of what's happening to folks now, what pathways are they traveling. And we also got a better sense of what are the core critical elements of service in terms of a Restoration Center. So we know people are accessing law enforcement and mobile crisis teams currently, and we want this center to be accessible to both of those streams. So we want this Restoration Center to be able to take police drop-offs, and we also want it to be able to take ambulance drop-offs and mobile crisis team transports. So that was one really critical element of our model that we incorporated based on all of this research. Another really critical part of our model you can see here is the triage and assessment function. So the Restoration Center really needs to be a place that can quickly take people in from these two sources, identify what their needs are, identify if they actually have a medical component to their needs, in which case they may actually need an emergency department level of care, or whether they can safely be served at the Restoration Center. So that's kind of the first really critical element that we identified from this data. And then the second really critical element that we identified was the idea that we would need to have a place where people could be to receive services, because what we were hearing from police anecdotally in particular, I'm sure is not a surprising refrain to any of you, which was, we often try to take people to the ED and we see them back downtown before we even return to town. And so we knew we needed to be able to treat a broad range of needs from folks that were going to be dropped off, so that the police really felt like this was a place that supported their needs, that was doing its work. So crisis stabilization beds up to 24 hours was an obvious critical component of this model. But also sober support was an obvious critical model based on, for example, our information about the number of people coming into the Middlesex jail and prison who require detox protocol, and the high rate of that detox protocol being opioid users and alcohol users. So our sober support model here that we're working on is intended to include both medical treatment for withdrawal symptoms, which are associated with those two particularly high medical need drugs, and then also having kind of a harm reduction model that can serve folks who don't need particular medical interventions for those withdrawal symptoms. And then the last important element of this model was respite, which allows us some flexibility, especially to deal with folks who might be homeless or not have a particular place to go after their crisis intervention happens, or might need a little bit more time basically to create a placement in, a sober home or some other kind of treatment setting that a person might need after they leave. And then there were some kind of ancillary connections that we thought were also really critical, like the ability to induct people onto MAT, again, back to those high rates of opioid use needs that we were seeing. So all of that data, it didn't all come from one place, and we weren't necessarily able to link up all of that data, from police departments to hospitals, for example. So we didn't, in this case, create a master database of individuals and actually see exactly, John Smith traveled from one part of the database to the other part of the database. But we were able to weave together all of these different data sources to build a picture of who is our target population, why are they interacting with the people that they're interacting with, and how could we change those pathways for the better to help divert people out. So you can advance to the next slide. So again, familiar to who, building that picture of the target population. We were really focused on improving access to the Restoration Center for police and ambulance drop-off, for people with both mental health and substance use needs, as we were seeing really high rates of both, and especially for all individuals, regardless of who their insurance carrier was, because one of the things that we were seeing was, it's much easier to access, for example, mobile crisis services in Massachusetts if you're a Medicaid recipient, but not so much if you are not a Medicaid recipient or if you're on commercial insurance. We wanted to know familiar why, and that really related to the intervention and the building of the model that we came up with. So really making sure that model is designed to address the underlying drivers of both arrest and unnecessary ED utilization. And then the last thing was looking at how are these folks familiar. So one of the aspects of the model that we kind of also built in was a commitment to innovation and continuous quality improvement. So really emphasizing the need to keep looking back at this data in the future on a regular basis, both in partnership with the provider entity that we are in the process of procuring now, to say, are the number of diverted arrests going up? Are the number of diverted ED visits going up? Are individuals receiving coordinated handoffs to care in the community after their use of the Restoration Center that is preventing future law enforcement or 911 contact? So we're going to continue to look at those outcomes as we go, now that we're at the stage of procuring our provider entity. And I know there was a question in the chat earlier about how long does all of this take? For us, all of this was over the course of 3 years. I will say, we use many different data sources to inform our work. And I think it's really at the outset thinking about what is the problem that we're trying to solve, for whom are we trying to solve it, and what are those individuals' needs. And I think that'll drive you to being able to find the data that you need to make decisions in a timely manner, even if that data isn't, for example, even if you aren't able to go to the local hospital and match all of their clientele with all of the clientele who's working with the police department at the time. So with that, I'll hand it back to Reggie.
Thank you very much, Katya. And so I think now, actually, we have some time for questions. Is that right?
Yeah, thanks, Reggie. We have several questions that came in, but I want to jump off of something, Katya, you just ended with, and that's to both of you, kind of that where do you start piece. You both talked about starting with criminal justice system data versus anything that has protected health information, but I'm assuming we have a site that doesn't have dedicated manpower, especially to look at data or to analyze that. What are your suggestions as far as where to start?
Katya, do you want to start with that one?
Sure. Yeah, so as you can see, we sort of to use someone else's term, built the plane as we flew it. So, you know, we started with the two initial data elements of high behavioral health utilization of EDs and a high proportion of behavioral health needs at the jail. And then we said, okay, why is that happening? And that kind of led us to different data elements. And, you know, a relatively quick thing that we did was this police survey, where, you know, we could, the staff who were working on this project could really just develop a survey and get it in front of police departments. And that yielded some really vital information for us, and at a relatively low kind of lift. A harder lift was where we did need, you know, some actual data analytical work. You know, I'm lucky that I was able to do the data analysis, but we did get, you know, de-identified data from our mobile crisis team providers in Middlesex County, and so that requires kind of a dedicated resource. So that's kind of why I put in the plug for the Harvard Kennedy School Government Performance Lab, because you know, the role that I played as a fellow there is to be basically that free analysis support for different states and counties who are looking to do this kind of work. So you can apply to receive technical assistance, and it's a free resource for folks. You know, another thing that you can look into is local universities often do similar work to this. So you might be able to get that analytical capacity to support your work for kind of free or reduced cost.
Katya, thank you. And if I can just also say that, again, we came at this, again, looking at an individual and a system lens. And the reason that that was important is that we could share that. So we were not sharing it that because this population we knew had mental health. That's not how we were sharing it. We were simply saying that there's public information on people coming through court. And so we were able to share that whole kind of list. And then over time created data sharing agreements with folks. It took some political pushing to get Medicaid and folks to actually look at the list, because they were all saying to me that, yeah, Reggie, we've already got that population. We know that population. I'm saying, I don't think you do. And so when they finally agreed to actually run that population, that's when we learned that only 18% of 500 people, it's like what, 74 people or so, had actual Medicaid. This is a population that's frequently coming through, but only 18% of them had Medicaid. And they were shocked at that. And so once we got the, oh, wow, shock from them, then they became great partners and advocates of this, because they started realizing that in fact, they were not serving this particular population, even though this population should be served by them, but it was being served from a justice system perspective. And then a costly ED. And so everybody then agreed, because that pain point all of a sudden had a new revelation. And then everybody agreed that we need to do something about this particular population and these costs.
Thank you both. So jumping off of that, Reggie, can you talk a little bit about the intricacies of cost shifting versus savings, and how it may not be such a clean, you know, cost avoidance or even cost savings, especially at the forefront?
Yeah, so I would always say, don't be, you know, our systems are largely penny wise and pound foolish. And so especially around insurance and that kinds of stuff, where people have to fail at the lowest level, even though they have complex needs up here, right? So we always do this kind of thing. And so with this particular population, I would say that you are never going to have a cost avoidance. You're just not going to have it. But you can get a cost decrease, and you most certainly can have a cost shift. And so we were able to start to track again, because we were able to look at this population that was largely being served through criminal justice, costly ED, and costly detox. And they were just flipping through that with no stabilization, that if we could at least reduce the number of times, the frequency of going back to the detox, going back to ED, because we are increasing our stabilization through housing and supported services. And so we still are paying for it. And I don't remember now, I've been gone from the city and county for 4.5 years. So I don't know what the cost is right now, but what I do know is we estimate it'd be about $18,000 instead of $38,000 to house and serve this particular population. And again, about 84% of that population has stayed stable in the housing, with the treatment and not gotten back to the jail system. And so again, the Urban Institute, and we can attach that report when we send out these slides, but really shows that we have been able to actually reduce that cost. Again, was a cost shifting to the right folks who should be paying for it. And for Colorado, it's an expansion state, so they picked up most of that. It also really taught us, though, when we created the co-responder, we were able to do a cost model and demonstrate to HCPF, which is the Medicaid state agency for Colorado, that we knew by doing co-responders and doing that front-end services to try to get these folks to services in the right place. And then by creating a solution center, what Katya was just talking about is kind of a stabilization center, that we would be able to actually further reduce cost. And in that, for our co-responders, about 60% of the cost we estimated would be covered by Medicaid, and about 40% we would cover. And that is in fact what we found. And so throughout all of this work, we were able to start to estimate what we think the costs were. And the cost measures we put together was, what's the cost to arrest versus the cost to do a civil, like a citation. It also started us pulling in probate court and looking at, which is really, I think, an underutilized service that should be taking place for folks with complex needs that we often are not utilizing. But we started really looking at, cost for a probate case versus a county case versus a state case. We started looking at the cost for booking, the cost for an average jail stay, again, both marginal and fixed costs. So all of that kinds of stuff became really important work to us. And then really took us down the path of 911. If I were going to advocate for people to start someplace, I would still say, look at your CAD data from your 911 call center, your PSAP, and look at either your jail or your court data. Again, the court data gave us a broader group than just jail would be. And it really pulled in this most visible person in a very different way.
Excellent, thanks. Katya, anything else you want to add around that topic?
No, I mean, I think I agree. It's really, it can be a wrong pockets problem. So, for us, if you think about our two main outcomes of interest, one outcome is a Medicaid pocket or a healthcare payer pocket more generally, which is the ED. And if we're trying to get folks to divert to a restoration center, the same pocket is saving money and paying for the project. But if we're trying to avoid arrest, which is the other part of our project, it's a wrong pockets problem. The savings accrue to the jail, but the costs are borne by a restoration center. So I will say Dave Ryan from the Sheriff's Office is on the call today, and he has done yeoman's work getting funding for the restoration center because we can't only rely on savings to pay for this stuff. So just wanted to shout out to him.
Excellent shout out. And that's something that we're seeing in the Padlet update. So feel free to look at that if folks want more information on the specific funding sources.
Actually, I'd like to share what I just put in the link. So going back to Katya's comment about utilizing your local universities, CUPSO is the consortium on university public service organizations. So if your local university has a public service-based institute, CUPSO is an organization in which they will be a part of. And your university-based public service institutes mainly focus on assisting state and local governments on a contemporary range of issues and challenges, which could be your data collection efforts. So when you have an opportunity, just pull up the directory under CUPSO, read a little bit about them, but they certainly will be able to steer you in the right direction if in the event that your local university does not have a member within the directory. If you're really serious about trying to see where you start, right? And utilizing a local university to help you do that at a reduced or no cost.
Thank you, Lisa.
Reggie, one more thing I wanted to direct to you. Katya, I know Middlesex is a little bit pre-implementation on this, but you mentioned I think it was rates of rearrest and how low that was with the group that was housed and access services. Can you talk a little bit about that criminal justice kind of utilization piece and whether you're saw lower levels after the MVP focus?
Yeah, and so again, this population became a lot of different groups. And so specifically for the slides I just showed you was specifically queuing up the social impact bond. So permanent supportive housing, housing first model. And on that particular one, great reductions. We also, another one of the channels are folks that were part of the recovery court. So we created a complete treatment court model just to serve this particular population. And so some of those folks might have also gotten to supportive housing through the social impact bond, others did not. And so even in the recovery court, housing or not, we were still able to see increases in stabilization. So reductions in criminal justice utilization, increases in cost, actually medical cost, right? Because they had chronic issues, chronic illnesses that were undertreated. And so we saw increased cost in both treatment for chronic issues, not ED cost, but ongoing treatment for them. And we also saw increased cost for preventative care, dental, eye, all of those other things that they were otherwise not getting. And so we saw increased costs in those things, but reduced utilization and cost in the more emergency room, even in the recovery court population that was not part of the housing part of this. I also want to put a plug in, and I don't know, Katya, if you've worked with the system, but I'm a huge advocate for the use of Power BI. So it's part of a Microsoft platform. It's free. You can take it with an Excel spreadsheet, and that's how you populate it. But you can get all kinds of really usable data from that. And so we put all of the programs that we created in Denver into a Power BI system. And then we're able to do reports back, both dashboards, but also really looking at various nuanced kinds of populations and see what those outcomes were. The other place that we saw great returns on and reduction in utilization, again, was that that group of folks who were part of state and county probation services, where there was otherwise a lot of revocations because the folks were not showing up at court. They were not showing up for their meeting. And so they would get a revocation on that. That was also by doing that day reporting center. That was also a great reduction in negative utilization, but increase in stabilization for the population.
Yeah, and to build on that, I mean, so we're at this inflection point now of going from all of this kind of background research to implementation. And one of the things that we're working through now is, okay, so we did all of these one-off data analyses and we produced all of this great material and we understand the problem a lot better. And those analyses apply to the individuals in the analysis. But how do we know going forward that our project is working? How do we kind of update all of those analyses over time? So, really focusing on how to build a project that will create data that tells us those outcomes. Not having to go back to all of these police departments and get all the same data again, or to all of these provider entities and get all of the same data again. How do we create kind of that feedback loop? One way of doing that is requiring data reporting as part of our contract with our provider entity, and then also building kind of prospective relationships with, for example, our state Medicaid agency to match that data potentially in the future, and with other entities to match that data as well.
Excellent points. Thank you. Reggie?
So if I would just add to that, pain points, right? There's going to be certain groups that are also so for us, it was the hospital, right? And so the Denver County Hospital, Denver Health and Hospital Authority also runs detox. And so they had significant pain points. Interestingly enough, they did a different study in looking at emergency room folks coming in, and that was a different population than ours. So ours were frequently going through the emergency room, but they had yet a different visible population that was coming through that was different. And so people were often assuming it was the same. It was not. So those nuances became important. Having, we did everything in a charter kind of system. So we chartered work, and then we created those intergovernmental agreement to have ongoing information sharing that took place. So that was another way that we're able to keep up with the data over time. They still, again, that list of 500 that we started with, now it became 1,400 folks that they've been tracking as being high utilizers, again, creating different cutoff scores. I would also say when they broadened that list, that population became slightly younger, slightly more drug involved, younger, right? I said before that we're able to look at the population and substance use. So they became younger, a little bit more criminal involved in other kinds of offending behavior. And so we also had to create new strategies around them. So again, just kind of really not getting too, I think, you know, don't let great get in the way. Don't let great get in the way of good, right? Start someplace and get curious about the data. I think that's one of the big parts, is really saying, so what does this mean for us? And many of our partners now have continued this work and are really invested actually in trying to use kind of a cross-system analysis as a way to help tell the story about those complex needs and pain points.
Thank you both. I would like to pause for just a second if folks want to unmute and ask any other questions. I think we've tackled everything that was in the chat, but this is an opportunity to do that, and you're able to just unmute. Otherwise, we'll talk about a couple of resources and the next call topic. So anyone that has additional questions? I don't see any unmutes right now. Okay, and we will send out all of the resources that were mentioned today, websites and other things with the recording and the slides if folks were unable to join or have colleagues join. So just again, to touch on this Harvard Kennedy School Government Performance Lab, this is a resource that's outside of the Safety and Justice Challenge. Both Katya and Reggie spoke to it. And they do a lot of research, but also provide pro bono technical assistance. And you can see the several different topic areas in your upper right corner there, and as well as where they've been active around the country. So feel free to reach out to Katya if I can volunteer you for more specific information given your experience, but also directly via the website, and they have a lot more resources on there. Also, this is, I know, a detail-rich slide, but this is the screenshot of a resource that we recently updated at Policy Research, and it's a look across all of the higher level of funded SJC sites, so the implementation sites, as well as the new 6 impact network sites, and where their behavioral health strategies are across the sequential intercept map. So we know that SJC sites have going back to 2015, a wide array of strategies that focus on local jails and other parts of the SIM model. Many of those are not focused on the population of folks with behavioral health needs. So this is a look, again, just at SJC strategies focused on that behavioral health related population. So this has been used for kind of site connection. If there's a site that's doing something that you're interested in hearing more about, peer-to-peer sharing. And the last time we had updated it was back in 2019. So this is just updated last month, and we will attach it to the email again with the recording going out after today. So you can see across the 6 intercepts kind of where sites SJC strategies lie. And a caveat that we note at the top, most of these, we tried to include strategies that were either funded directly by the SJC or at least kind of closely linked. So there are behavioral health programs and initiatives at a lot of these sites that existed prior to the SJC or with outside funding, things like that. So this certainly isn't exhaustive, but it does give you kind of a good at a glance of SJC behavioral health focuses. And then a little bit of a promo for our next call that we don't have a date yet, but we're looking at the last couple of days in April, actually, I think. This will stay within the Intercept 01 focus, and we'll be focusing on behavioral health modifications at this 911 dispatch point, which Reggie had a really nice lead into earlier. So looking at what sorts of modifications can be made at the 911 dispatch point. We'll be hearing from another policy research colleague as to a diversion program that he developed in New York County at the point of dispatch that's been expanded. It is based on the crisis call diversion program in Houston, Texas. And we'll also be hearing about embedding behavioral health clinicians at dispatch and other national efforts to transform that 911 dispatch point, as well as a little bit about 988, which is coming up very quickly in a couple of months. So stay tuned for the date and more information on that call. And then in future months, we'll move into intercepts 2 and 3 and farther down the model. So any final questions, or Reggie or Katya, anything from you before we close today? See no new questions.
Let us know if you guys want to think through any of your strategies and trying to really dive into the data, look at these particular populations, really kind of thinking about your theory of change. We're happy to have those conversations with you to help tease it out.
Absolutely. Thank you both for your time and everyone for joining, and take a look out for that email with resources. Have a great day.